All right, so welcome back. We're now starting into our next session, and here we're going to have a number of commenters on the previous paper by Richard Burkhouse. We're going to begin with Michael Donnelly, who's the director of the Kansas Rehabilitation Service, and then Bob Steggert, who's a former vice president of casualty claims with Marriott International. Then Andrew Houghtonville, who's associate professor of economics at the Paul College of Business and Economics at the University of New Hampshire. Then David Wittenberg, a senior researcher at the Center for Studying Disability Policy at Mathematica. And then Dorcas Hardy, who's a former commissioner of Social Security. So let's begin with Michael. Michael, I wonder.
Excuse me. Yeah, I think that's the way to go. But we might have to.
You're fine right there, and let's put the chair here, okay?
Okay, there we go. Well, thank you very much for the opportunity to be here. I sort of come at this from a little different perspective as rather than all of the numbers, but what I can tell you is the numbers matter. I'm the director of a vocational rehabilitation program in the state of Kansas, a little bitty place with big ideas. I also, as a part of my role, oversee the Disability Determination Services program for our state. For me, this is kind of an odd place to be, simply because our DDS, for 7 years in a row now, has received a commissioner citation for accuracy in claims, their speediness, all of those sorts of things. And yet, what we've seen is this huge growth in the number of people both applying, and as a result, 38% being awarded benefits, and then on top of that, 17% in the review of those decisions that also get to be on the rolls. Those are people that I know. I've been in the disability field for quite a long time, and I know that we can pretty well accommodate most people who have a disability to work. To work SGA level, all those sorts of things, and I think that that's where I come at this from a little different perspective. At 17, I became a quadriplegic. I'd worked on the farm, I'd worked in meat processing, all kinds of things like that. Just because the next day I happened to be a quadriplegic, I was assumed to be unable to work. Doctors, all other professionals told my mother, take him home and take care of him until he dies. That's not really the approach that we need. And somebody this morning talked about early intervention. How do we get to people quickest? Well, that's when you have to get to them. What we know is if a person takes the time to apply for Social Security disability insurance, if they take the time to ask for reconsideration, and then they go through the 2-year or plus process of administrative hearing in order to be awarded benefits, they've lost pretty much all the skills that they had in the connection to work. They just really have. So those kinds of things I think really do in fact need to be examined from just this personal approach to disability. The other thing that we experience, and we've had to make some decisions about this recently in Kansas, is all of these other programs have incentives to get that person who's newly injured, that get that person who's just turning 18, and have them go down this disability benefits track. You know, kids that leave high school on SSI will spend an average of 27 years on SSI. Who's that good for? It's not really good for anybody. It's not good for that person. It's not good for our states, our taxpayers, the whole thing. It's not good for any of those. But if you apply for TANF and you claim that you have a disability, the first thing that happens in our state is, or used to until last year, you were exempted from having to work, to participate in work activities, those sorts of things. And instead, we paid an attorney to help you get on the disability rolls. Was that the best thing to do? What we end up with in vocational rehabilitation, and something we fight with all the time, is we're a program that's returning people to work, yet we have our counselors, who are those soft-hearted people that we're talked about, who will spend tremendous amounts of time, resources, and energy on helping someone prove they can't. And they're involved in a program where they're trying to pursue work. And so you get this really bad balance between some of the public policy and that sort of thing. One of the things that in talking with our DDS folks and other folks in my field around the country is it's very clear DDS system, the termination process is really broken. They know when they do those things, and again, we've got some of the highest accuracy rates according to the standards in the country in our DDS. They know when they're talking on the phone to that individual that they are perfectly capable of having a job of some sort. But things like the grid, who, you know, you go through and go, okay, this is the condition, this is their age, this is what they've done for all their life, oh, yep, pass. Or nope, they did have a sit-down job, therefore fail. The guy that's 49, who's had sedentary jobs all his life, or not sedentary, but labor sorts of jobs all his life, the day he turns 50 is considered to be approaching advanced age, therefore unable to learn a new job. It doesn't make any sense. And I mean, it's 15 pages long of that sort of grid and how that all works. It really doesn't help people actually return to the life that they really do want, which is to be employed, to have a social life, to have an income that they can choose where they live, all those sorts of things, and that's kind of awfully important. One of the things that we do in rehabilitation, vocational rehabilitation at least, is that we focus on and assume that everyone who comes to us is in fact capable of working. It's a presumption in the Rehabilitation Act. Everybody is assumed to be able to benefit in terms of an employment outcome when they come to our program. It's a very, very, very small percentage nationally that are found too disabled to work. It's a very, very small percentage. I don't know why we don't adopt such a thing in our other programs. The standard in the Rehabilitation Act to determine whether or not a person is too disabled to work is clear and convincing evidence. It's a pretty high legal standard. You have to have tried jobs, you have to have done vocational evaluations, you've had to do multiple stages to determine whether or not that person can or can't work. And more often than not, they can. And I think that's a model that ought to be looked at personally. One of the other areas that I feel pretty strongly about is the variety of systems in the disability world that encourage people never to leave the rolls. There's a reason that only 1.5% ever leave the rolls as a result of work. And that is if you're a person with an intellectual disability and you have this huge DD system that's funded by Medicaid dollars and other dollars in your state, they don't want you to leave that. They don't want you to give up your Medicaid. They don't want you to leave the group home, the sheltered workshop, the whatever, because it's a pretty big business. In our little state, that's $300–400 million a year that those folks are making on the backs of people who they want to have stay in the Social Security system. Those kinds of incentives for those programs really need to be flipped on their head. They really do need to be turned upside down. So I know I only had 8 minutes, and I'll just sort of leave that alone and go on to the next person. So thank you all.
Thank you.
Thank you, Ron. Good morning, everybody. It's a pleasure to be here today. A little bit of caveat. The background information says I am currently employed by Marriott International as the global claims officer, and that's wrong. I recently retired from that job after 3 decades. What I've been asked to do today is to talk to you about disability primarily from the workers' compensation perspective and give you some sense of what success we've had in disability management in that realm. By way of background, Marriott 30 years ago was not a very good employer from the standpoint of preventing injuries and managing risks efficiently, whatever the system was. They were in what the insurance industry called an assigned risk pool back in the 70s, so bad from an experience basis they couldn't get insurance. We made a commitment 30-some years ago to change that. I was part of the tail end of that, and as recently as a couple of years ago, we won a industry award, the Teddy Roosevelt Award, for the best disability management program in the United States in the workers' compensation area. So it can be done, starting from the dredges to the best pinnacle award the industry can give you. The payor in workers' compensation, as you can appreciate, is oftentimes an insurance carrier, but about 30% of the market is self-insured. Marriott was part of that self-insured population. We were both self-insured and self-administered, which means that I had internal staff, both claims and nursing and physician staffing, to oversee the effective disability management of our cases. To give you a sense of that, we had roughly 25,000 a year domestically in the United States. Even though I was responsible for global affairs, only about 75% of my time was spent domestically in workers' compensation matters. With that subset of disability claims in the United States, we spent roughly $100 million a year. So Marriott was a large employer. Severity was not often a factor. It was more of the traditional musculoskeletal injuries, stress, lifting, twisting, etc., that we have in the service industry that cause problems for us. Fundamentally, our nurses intervened in these cases very early on. We were the first employer, I think, in the United States to literally have a nurse on every single workers' compensation case, including no lost time cases that just had medical care. That sent an early signal to the injured worker that we cared about their recovery. We expected them to come back to work. We expected them to cooperate with the treatment and to be active in the disability management process with the site upon return to work. That always wasn't the case, obviously, with being a human organization. And in cases where we did not see recovery from a recovery standpoint consistent with what we generally call evidence-based medicine and anticipated recovery timeframes, my staff was trained to ask the overall simple question, why? And you just kept asking why until you got to some type of reason where you could proactively address that disability situation. And oftentimes we couldn't answer the why. And in short, one of the things we did creatively following the Netherlands program, actually, we did some research on a couple of years ago, was to do some things that are traditionally outside of the workers' compensation arena, and that's to try to get a better sense of the real or contributing origin of disability. It is often not the broken leg or the broken arm or the twisted knee or the low back alone that causes disability. The vast majority of cases have got some type of other factor, whether it's a comorbidity or it's a psychosocial factor. They do affect human beings and their incentives and systems to return to work and to become active players in society. That's one of the things the Dutch did very well by articulating that they expect their population to contribute to their society, and just because you happen to have an injury on the work and just because that employer or the insurance carrier pays for that entirely, medical care, disability income, partial disability income, and in fact permanent total disability income in terms of people that are quadriplegic and can't work, or whatever your condition is, that is expected, and that is that's the right place for society to fall down. When we started asking these why questions, we were amazed at the variety of reasons, and believe me, my staff gave me a fair amount of backlash about this. They said, Bob, the statute in this state says you don't have to pay that, and I don't want to open up Pandora's box by doing a psychosocial analysis, because under my state, I may have to pay X% in permanent disability for a mental impairment. And we said, well and good, but there are now, and I won't get into too much detail, Jennifer and others knows that, there are codes that you can attach to cognitive behavioral therapy interventions that don't necessarily result in permanent disability impairment. They simply are an early upfront effort to legitimately help to understand what is going on with that person. Do they have a dependency issue that is outside of the injury? Do they have a financial situation they need help with? Do they have children that are problems, that are drug addicts or what have you? All of those factors obviously can affect their attitude, their ability to work and return to work and become successful individuals. I can tell you we don't have a whole lot of statistics on the intervention program. There's we call it a PAD program, a psychological assessment tool, and we're measuring that. The statistics aren't quite ready to divulge yet, but we have had a number of successes. I'll just give you a couple of them to give you a sense of it. We found out one worker, actually it was a 25-year housekeeper, who was a female and who had put on some weight and had some other comorbidity issues. We also found out that she was homeless. Imagine that, a 25-year associate of ours who had become homeless. Well, we found out her husband had died and that she couldn't afford there and living in a car. So we got her to some services and we took care of that, and in fact we turned that around and got that person successfully back to work. We've also uncovered the host of people that you can imagine with other issues, psychosocial dependency and the like, and we steer them to appropriate interventions to try to get them to come back to work. So I've got to wrap up now. It's not a panacea. I will, one more brief comment on workers' comp, just to kind of wrap to make sure you understand that. Workers' comp has got incentives that are quite different than other incentives in terms of disability income. While they're unable to work, permanent disability, you lose a digit, you get paid money for that. If you can't do certain aspects of a job, occasionally that's rated out in that, and you get permanent disability benefits. That often in workers' comp is contentious and is litigated, and too often it's win-lose. But by being a proactive employer and trying to understand the why question and doing what is right at the bottom of at the end of the day from a fiduciary mitigation standpoint, does pay benefits and is very helpful. So I'll be happy to take some questions later, but I will cede the rest of my time to the panel. Thank you.
Bob, thank you very much. Andrew, Altonville.
Thank you. I have slides as well. I don't know if they're up. Thank you. Imagine if retirement benefits were based on not how old you are, but how old you feel, right? Thank you for laughing. You want your benefits. Imagine if survivor benefits were not based on whether your spouse or parent died, but how good a parent they were or how good a spouse they were. Yeah, everybody's kind of nudging, right? Well, disability is, as Rich had pointed out, is much more of a complex phenomena than age or life or death or survivorship. If we believe that the disability determination system was 100% correct, right, unable to work above SGA, then we wouldn't see a bunch of economists in this room. So it wouldn't be green eye shade guys, right? It would be white jacketed clinicians, right? Medical, vocational. Well, I guess vocational people don't wear white jackets, but and so we wouldn't be talking about the effect of economic factors if we believed that the disability system was 100% correct. Also, we wouldn't probably have such doubt in the determination system if Congress did not ask SSA to do a Herculean, impossible task of assigning a 0-1 to whether someone can or cannot work above SGA. Right? It's also unfair to ask individuals with disabilities to gamble on whether they hit that mark. Right? To be asked to stay out of the labor market for a year and a half to 2 years for some people, to go through an adjudication process, all on the basis of information that's collected primarily just at the field office, not in person, right? It always surprises me that it's my understanding that an individual will file their paperwork either online now or at a field office and never see another individual until they receive their denial. Until they go to an ALJ, they will never see a person or talk to a person. It's all by paper, and I'm sure it's great grammatic paper letter writing, and it's very clear descriptions of why a person was denied. I'm sure that's the case, but if we had 100% belief in the ability of this system to determine disability, we wouldn't be here today talking about a lot of economic issues and incentives. So what I'm going to talk about today is an experience. I've been working a bit with people in the medical rehabilitation and vocational rehabilitation field about functional assessment. All right, so why don't we go to my next slide? Oh, that's me. Let's hope I get it right. It's upside down. Yeah, I guess my palm. There we go. So Social Security disability insurance. Disability is very different than survivorship or retirement. The expectations are higher, and disability is not immutable, as Rich had mentioned. Oh boy, that was not good. There we go. I got it. Thanks. The statutory definition by statute is the inability to engage in any substantial gainful activity by reason of a medically determinable physical or mental impairment. There are lots of other caveats after that, but that's the essence. Modern concepts of disability focus on functioning and allow for the role of the environment to be influenced. So accommodations, workplace accommodations, 3 minutes, thank you, can get you along the way. They call for there's a call for a more comprehensive assessment of function and to assess the capacity to work. Measuring human functioning and the job requirements may hold promise for SSA in the determination process and the data collection process, also in the provision of early intervention services. The DDS collects a tremendous amount of information about medical information, but it's not used later on. It's almost forgotten, and there's a lot of information that is collected that could inform early intervention. Functioning, this graph might be a little too small for those in back. Those in back can look behind them. That's what I'm looking at. There's personal functioning on one side, and there's the functional requirements of a job on the other. And this is using ICF categories: basic mobility function, cognition, personal interactions. That's a challenge sometimes. Communication, self-care, and general tasks and demands. And what we can do is you can actually develop functional assessment tools sometimes based on self-report, but also verified by clinicians. And who counts as a clinician is an issue. And so what you can do is understand the basic functioning of the individual and also the functional requirements of the job. And then you can talk about what modifications can be done to improve the function of the individual. What modifications can be done to reduce the functional requirements of a job while still maintaining wages at the same level. And so there is this movement within the Med Rehab group and Voc Rehab to develop these types of assessment that can be quickly done and accurately done to place people on a spectrum. So if you've taken exams, if you've taken any exams from education, you're always put on a proficiency scale by asking specific questions. And these are the kinds of functional assessments that are being developed. If you quickly look, I don't have time, but if you quickly look at what the Form 33868 asks for when you go to the field office, it asks you about your illness. It asks open-ended questions, very descriptive open-ended questions about your condition and its influence. Then it asks you for your doctor and hospital records, names, dates, and then it asks you for your medication, your tests and treatments. This is a long way from the concepts of disability that we have today. It's a long way from helping early intervention. It's a long way from making accurate decisions. And I would say that making accurate decisions, whether it's in a short-term system, is the way to go. And I do have a degree of sympathy or agreement with programs that do it at a local level, right? Whether it's the firm or the state or the county level, seeing individuals is an important aspect. So before Ron kicks me out.
My popularity is increasing by the minute here. So David Wittenberg.
All right, I'm going to talk about the SSI portion of Rich's presentation, and I think a natural starting point, as Ron, you mentioned, is to really discuss what I think can agree on, and also discuss what we don't know. So why don't we start with what we do know? And I want to make 4 points about what we do know about the child SSI population. And I think the first point is really potentially the most important point in thinking about options for change. While all youth share a common impairment that satisfies SSA's disability criteria, within that population there's major variations in the impairment and functional capacities of the youth, both in the physical and mental impairments. They also come from families with differing characteristics and needs for supports. The second key point I want to make is the importance of the SSI check. It comprises approximately half of the family incomes. Hence, we're dealing with a very economically fragile and vulnerable population. The third point I want to make about what I think we know is that child SSI recipients have relatively poor outcomes. Now, those outcomes may reflect the outcomes of other youth with disabilities, but there are major concerns about the programmatic incentives for investing in the youth's education, given the ongoing SSI programmatic eligibility rules, work rules for youth, and the age 18 redetermination. And the fourth point that I want to make is about the differences in access to other state and local services. And as Rich really emphasized, states have different approaches in providing not only services to people with disabilities, but also to the low-income population more generally, which has influenced major variations in child SSI participation rate across states. So that's what I think we know. The bad news is what we don't know. The outcomes that I suggest, I think, indicate that we should be trying to do something different, or at least testing to see if we can do better. But unfortunately, I don't think there's an inadequate basis for how to do that. Without such knowledge, any untested option could result in harm to economically vulnerable families and or even result in more spending on cash programs. I want to talk specifically for a moment about Rich's idea of block grants. And I think that there is promise at the state level to be able to coordinate incentives and not only coordinate incentives, but also with TANF, but coordinate services such as VR and Medicaid that are delivered at the state level. So while there's potential at the state level, the problem with a block grant is one of the outcomes could be that some states would do better, but other states could do far, far worse, in part because there are these huge variations in state service availabilities and state capabilities. And our past histories have suggested some state struggles in delivering these services, which in part gave rise to the federal SSI program. Equally important, even if a state was successful in a block grant, you could argue that there's no guarantee without some major federal oversight that the state wouldn't necessarily change its program in the future or change its funding to other programs. So for this reason, I suggest a more balanced approach, especially given that we are dealing with decisions that can affect long-term outcomes. These approaches are especially important as we consider alternatives for youth. Much like when we consider returns to education, it can take several years for returns to youth with disabilities to develop. And additionally, these considerations should look at other costs to state and local programs, particularly given that child SSI recipients are at particularly poor risk for outcomes such as arrests. So where can we go from here, given that we have an inadequate basis for fundamental overhaul? I think the YTD demonstration offers some potential lessons because it provides a rigorous evaluation that shows strong employment impacts for a population of transition age youth, primarily on SSI. And I think what is interesting about the YTD demonstration is that in some of the sites, the youth and the providers were clearly focused on employment as the outcome. There was a clear aligning of the incentives. And in one of the most successful sites, the employment rates increased by approximately 20%. So what do I suggest? I suggest going bolder than YTD and testing the integration of cash with other employment supports, particularly those offered at the state and local level. The bolder aspect of YTD would be the integration of cash and employment supports, but the cash would be delivered through a different set of supports. I'm being told that I have to wrap up. Does that mean 1 minute or done? I'm done. All right.
Do your second one quickly.
Oh, do my second one. Okay. So the second option is we don't necessarily have to do this all at the state level, but you could test designs to promote youth outcomes. And this is something similar to Brian McDonald's idea of changing the redetermination age from age 18 to a more youth-centric transition-based program of extending benefits to age 30, where you clearly define the supports and the outcomes and the end dates. And there are various options in between here, but I think the fundamental point is we don't know yet what works, and we have to be very cautious in developing that evidence basis before making a fundamental overall. So,
Thank you.
Thank you.
Dorcas Harding.
Thank you to you all, as my colleagues, panelists, et cetera, for this opportunity here. I wanted to spend just a few minutes with you looking at some possible changes that could be made regardless and incorporating, so both sides, of what we've been talking about this morning. Most of them are administrative, but I want to remind some folks that there are things that we can do that don't necessarily have to be statutory. I can't quite imagine that we could change everything and have it all start again better, perfectly, et cetera, tomorrow. So we can look at some of the issues that we've all kind of know about. Some of the examples on how we could do things better would be the compassionate allowances, as well as the quick determination decision-making that the agency has undertaken over the last several years. I think we need more of that and kind of a sense of urgency at the agency to make these kinds of changes. A lot of people are going to tell me nothing, it can't be done, we got to wait for total overhaul, all of that. I don't really agree. I don't agree at all with that line. So what are some other ideas? Consider revision of the SSDI benefit structure. And under that kind of category, I think we could be looking at using more of the new medical knowledge, using more technology for functional assessment, as Andrew was talking about function and how that relates to all of this. It's clearly used widely by the private sector, and perhaps we should be able to make a lot better decisions on all of that. Obviously, this is for applicants or for beneficiaries who are generally expected to have some kind of improvement. And for many of these folks, why not consider temporary benefits? We've had that conversation in and out of over the years, but we're still not there yet. Perhaps there should be 3 to 5 years, then their status gets reviewed again. And within that, we also need to continue to do a lot more CDRs, I think. There's a lot of conversation, some conflict about dollars with that, et cetera. I'm just trying to move beyond that. I think we've got to do a lot more CDRs. We started postcards to folks when I was there, which was more than a few years ago. And I have a feeling the agency is still doing postcards. I think we could do better than that to get people more involved with their own. This is assuming that an individual, a beneficiary, is able perhaps to go back to work. So there's got to be, it seems to me, a more consideration of what might be the best process at the front end to do more CDRs. We have early and focused interventions we've talked about a little bit earlier here from the VR, from the private sector, but I think we need to be more creative and more innovative about trying to figure out how this program within the administrative structure can be even more improved. A lot's been done, no doubt about that. We also, I think, should be considering how we could simplify the complicated work incentives that we have and look at the benefit offset idea. Very clean, very simple. There are many people on the rolls we all know who can work to some degree, but are afraid, and not surprisingly, to work beyond SGA because they obviously have that cash cliff. So is there a better way for those who can and want to work to figure out how to work at least up to their capacity and give them, quote, credit. I mean, be supportive of that. Perhaps the Congress needs to think more about how, not if, that we can follow the successes of the bond four-state pilot and work with states who do want to participate. That would be a 1-for-2 offset. I think most of this audience is very knowledgeable about bond. And I don't think all of this conversation, which is about bond, which is supposed to end in 2017, I haven't seen very many projects end on time. And so I think about 2021 or so is what others have told me, that why do we need to wait that long? Let the states step up, say, I'd like to do this. And I believe you could put together a group like in this room, and you could get a very focused program in place, which certainly may not be perfect, and it may need some other assistance as we go along, tweaking or whatever. But that could be, I really think, you sit down one place, you could get that put together in 6 months. I mean, this is of concern. We've spent a lot of time talking about disability. Is it right? Is it wrong? Do we fix it? Do we not fix it? Well, then let's just move on and do some things that the states, I think, like the 4-pilot project, we just go ahead and do it. 1619 A and B is kind of like a good example of that. Way before I became Commissioner of Social Security, Alan Jensen and I worked with Congressman Steve Bartlett from Dallas at that point in time, put together and were very supportive of the whole temporary, of that entire program. And once everybody was on the same page, there certainly was a concern that there might be induced entry onto the SSI rolls. So when that induced entry did not materialize, it was made permanent. The program was made permanent. A DI benefit offset could certainly be implemented in a similar way on a temporary basis, say 3 to 4 years to start all of this. I think there's a variety of options out there. I don't think we're quite thinking as broadly in terms of the administrative side, the program side, as to how we could make improvements. Obviously, our collective objective is to serve our beneficiaries or prospective beneficiaries effectively, smartly. The administration of the program is extremely important. It's definitely a challenge, and especially when we've had the increase in roles, I will not get into who's right and who's wrong as to why. The recent changes have been made, but I think we could do a lot more. We need to also, there's a couple of other items here, and one is the restoring confidence, which is moving along in decision-making and reducing appeals, decreases in backlogs, and also supporting more comprehensive training of our ALJs, thinking about how we might move the administration of the ALJ training and selection to the administrative conference, as opposed to where it currently resides at OPM. We've got an archaic vocational grid that Michael talked about, and Ron's going to beat me up, and the integration of function in this whole thing. And lastly, to say that I think Dr. Burkhauser's idea and others of returning this to the states, which I would have liked to have done, and SSI being state-based, federal arch, but state-based. So that's where we are, and hopefully we can get some things done.
All right, now's an opportunity for people in the audience to make comments or to raise questions. Yes. Someone's going to bring a mic, so.
So given that the Affordable Care Act may provide some different opportunities for people to access coverage, I'm still wondering, for any speaker who's interested, if they might be able to address the potential of a stronger delinking of publicly financed health care from cash assistance for people with disabilities and implications for employment.
Oh, interesting point. Any of the speakers want to address that? Yes.
I know for people with
Yeah.
Yeah, for people
Stand up,
with-
would you please?
For people with mental health disabilities, a fear of losing health insurance is the #1 concern that they raise about working. People who have schizophrenia need their medicines, need their treatment team. They want to work, but they can't afford to lose their health insurance. So we're all hopeful it will make a big difference in the mental health field.
Other questions or comments? Yes, all the way in the back.
This is a question about the bond, and I know there are people in the room who know a lot about the bond, and also referring to what Mr. Wittenberg said about not doing things that are untested. Are there things that we don't know about the bond that imply that there could be damage by further rollout?
For bond, I think one of the key early implementation lessons from the evaluation was the challenges in bringing the beneficiaries up to speed on the information about bond eligibility, and the numbers of offset users originally was fairly small, and there was a concern about beneficiary understanding. SSA is trying to address that in the demonstration right now. But I think there is a general concern in rushing any program out too quickly. I mean, and that includes bond, it dates back to Ticket to Work in terms of the provider incentives and things like that. I think having well-defined pilots before you go out to the field is really, really important, because what you don't know could really, really hurt you.
So I take that's a yes. Yeah. Other questions or comments? Yes. We want to be front and back so this young lady can get plenty of exercise going back and forth. Right?
Hi, I'm Andy Imparato. I work for the Senate Help Committee with Senator Harkin. And I guess I just want to suggest a different frame, and I think you're going to get into this in the third panel. But the way we're looking at this, Senator Harkin wants more people with significant disabilities to participate in the labor force. That's our goal. And, you know, the way that this discussion has been framed, it starts with the economics and the economic imperative. It moves to, are the wrong people on the benefits? And what I worry about is I don't know that we're going to get quick bipartisan consensus on either of those issues.
Oh, that's shocking.
I think it's easier to get bipartisan consensus on, let's do what we can to get more people in the labor force. Let's figure out the interventions, and when in the life cycle of a person with disabilities, those interventions are going to get the greatest return on investment. And I'm just suggesting that if you frame it that way, it's going to be easier to have a bipartisan conversation. I appreciate what Dorcas said, that there's things that Social Security can do without congressional action. I think that's going to be important. But I do think there's some hope for congressional action if we frame it about growing the size of the disability labor force, as opposed to, we can't afford these poverty programs, or we've got all these malingerers on the rolls who don't belong there, which becomes very partisan very quickly.
Right. No one said malinger, I don't think, but your point is very well taken. I think you're exactly right. And this is especially the case, no one has talked about this very much, but the overall labor force participation, especially among males, has been declining, and now even females. So this is a broader issue, and I think you're exactly right. That would be a way to frame it, although I think you're still going to get into difficult issues about what's really driving the roles and so forth. So any other questions or comments? Yes, and I'll come to you next, in the back.
There seems to be a lot of confusion or misunderstanding about what went on in the 80s with DIBRA in 1984 and the period before then, whether or not that constituted a massive loosening of the roles and that resulting in more musculoskeletal and mental impairments. I was wondering, for the people who lived it and who were in the field around that time, what's your recollection of what happened during that period? I mean, was it in fact a massive liberalization of the roles, or was it perhaps a leveling out of what had occurred earlier when there was a period of a tightening of the roles and people being thrown off the roles?
It would be great if someone from the Social Security Administration would give a view on this. Dorcas. I'll pick you at random. You might not be at Social Security Administration, but you're honorary. Would you rather not? Pardon? Hand her the microphone. She's from Washington. She'll talk when she has a microphone.
You never give up. I was just saying to Ron, I didn't get there till 86, but my recollection are things that don't necessarily answer your question. That's my concern. We had Zebley, if I remember, which was late 80s. We had some other issues similar to that, whether or not that was a point, absolutely a point in time that would answer your question. I would have to go back and look at some notes someplace. So I apologize.
Well, that had the virtue of being short.
But Andrew may know.
Oh, Andrew, okay.
No,
it has to be short, though.
No, I would just say that for at least for mental impairments, you'd really have to be careful making those kinds of statements because lithium was coming out at that point. People were coming out of institutions, including my father. So,
last question right here.
Just a quick comment. I agree with the discussion about the approach to discussing this with Congress. I think there's a different way of approaching that, and that would be a good one. And then there was some question as to we have to look at what might work. Well, all of those things that what might work exist today and have been tested through the private industry. Bob Steger gave a great explanation of the workers' comp piece in his last company. But those things exist today, and the cool thing is, if you look at the numbers of individuals that private insurance or employer groups are working with, some of those exact same individuals are people on SSDI. So it's apples to apples, not apples to oranges. And I would suggest that there are some immediate things that we can all do to get together, have real discussions that won't go on for years and years and years, and say, here are the 5 things that we think Social Security could grab onto very quickly, very easily, to use in their early intervention case management process of a claim.
All right, those of you who know Jason probably know that he's quite a marshmallow, and he thinks we need a break. And since he's running the thing, we're going to have a 5-minute break.